FIFA, PGA, some Madden, computer graphics design. Yeah, resting a lot and doing hand therapy. Okay, well, for the people that are in here right now, we have around 14 people. Why don't you guys help us answer this question? What percentage of people in the US deal or are dealing with wrist and hand repetitive strain issues? Drop your answers in the chat. I changed this to low latency so we don't have to wait for the delay as much as possible. So let's hear it. And I wish I could play music, that would
I can sing.
For the response.
Do 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 don't.
So one guess is 40%.
40%.
RuneScape, 16 hours a day. Okay, well, yeah, that's especially if you're talking about old school RuneScape. Whew, that's really high APMs. Now
16 hours a day of RuneScape. That's crazy, brother.
It truly is a lot. Not as bad, guys. We're not that bad. Okay, it's 10%. 10% of the adults. It varies depending on the study. So around 10% of people report dealing with some form of RSI distributed in these patterns that are shown here, P1 through P10. And if you guys want to drop in the chat which number you guys are experiencing. Who's dealing with P1s or P3s in the chat? Any P5s or P10s, right? We got any P10s in the house? And as you know, most of the RSI is related more to wrist and hand. Okay, so 1 in 10 people, all related RSIs for the entire body, but wrist and hand around 36% of those people. But generally, just a lot of individuals who are, whether it be physically demanding jobs or their hobbies, or because they're spending so much time physically inactive over several years, they will develop or are at risk for developing repetitive strain. So let's count up some of these. Lots of P6, right? P6, P6, P6. Guys, this is the RuneScape player, right? 16 hours a day. And, for the RuneScapers, when you're RuneScaping, you're clicking a lot. There's a lot of clicking, right? There's a lot.
Turn your mic up, Matt.
There's a lot of this. And look, this is where P6 is.
Turn your mic up, Matt.
Oh, turn my mic up? What about now? Okay. Sometimes my mic will auto switch for some reason and see it's going down. It's kind of weird. I don't know why it does this. It's kind of annoying that it does that. But yeah, now clearly you guys can see there's a bunch of different pain patterns. P1, P10, fingers, P2, the top side of the forearm. We also have P8, which is the thumb. Again, we'll be explaining and providing a lot more details about all of these in the next hour or however long it takes for us to help you guys understand more about this problem. Is my mic still pretty soft? I'm just gonna move it closer to my face because it keeps automatically going down. How are we doing? Is my mic pretty good here? Elliot, we good?
Yeah, feels good.
Okay. Now, before we go on, we're gonna quickly go over who we are. If you guys are here on our email list, or if you are here from our Twitter or our YouTube, you might already know, but let's quickly go over it. I'm Matt, physical therapist, orthopedic clinical specialist. I also did a residency, and for those that don't know what a residency is, it's basically, think of having a guy sit in the room with you for every single patient for an entire year to challenge every single decision that you make. It really helped me what I call develop a sniper rather than a shotgun, in terms of when many physical therapists graduate, they tend to have this shotgun-based approach. It helped me develop a sniper. And then Elliot is physical
therapist. I'm a doctor of physical therapy as well. I'm also a certified athletic trainer. I come from a background of working in the entertainment industry with performing artists. Started working in the esports industry with Matt about 5 to 6 years ago. really developed a strong understanding through field testing a lot of these protocols in the professional esports scene. And a lot of the protocols mimicked a lot of the evidence that we were kind of going through when I was doing my master's in performing arts. So working with like musicians and things like that. So we combined forces and we've really developed some solid protocols for kind of addressing these repetitive strain injuries in people that are like high performance individuals that like need to work with their hands. So it's been a wild ride, but yeah, we'll kind of start at the start here.
Yeah, we're gonna do a speed run of the story. I started 1 HP in 2015, pretty much 1 year after I graduated, because I saw people were retiring due to their injuries, and I thought it was kind of ridiculous that we with small repetitive activities people would not be able to use their hands again with proper rehabilitation. So when I looked into it, they weren't actually getting the rehabilitation that they needed. So I felt like, hey, let me actually be the one to help these people. I started making content. I reached out to every single owner of every single esports team. I got lucky enough that CLG picked me up, and really, it kind of snowballed from there, where I started with CLG, then went to Immortals, then went to work with Overwatch League team, then started to work with Valorant teams, Fortnite, Call of Duty Pro League, worked with teams, not only in the United States or North America, but also EU, some South American, some Southeast Asian teams. We've literally worked with people all over the world, every major esports title. You can see here some of the work that we've done with a few pros. Here's me and Elliot. We spent a lot of time with 100 Thieves. This is early CLG days. Masu for the fly people that are following League. We've worked with FlyQuest for quite some time. And then here's us doing posture checks at the tailgates. And more, right? Not only, directly working, what's important to us was, hey, helping more providers, Alex Hayes, fellow physical therapist, understand how to work with the gaming population. But then we realized, okay, well, in the past 5 years, there's also these musicians, there's also artists, there's also software engineers that finish work and then go game. And we realized that we could really expand our work to not only work with these pros, but help all of these other professions that utilize their wrists and hands on a regular basis, right? And whenever we would talk to these individuals, the story, and it continues to be the same now, where when they go to their doctor, when they go see their, hey, and his hair is probably not going to be brown, and he's not going to look like this. It's going to be white, and he's going to look a little bit older. He's going to, maybe have a little limp. No, he's not going to be like that. But what they typically recommend, and what we hear, is they're just told you should probably stop gaming as much, or let's take you off of work so you don't use your wrists and hands. Wear a brace, come back in 2 weeks, the pain should go away. And they just sort of leave it at that. Maybe if the patient asks some questions, well, how am I going to actually get back to using my wrists and hands? Well, if you keep pushing, we might need to do injections, we might need to do surgery. And hopefully you guys can kind of see a problem with that, right? A problem with that type of response. And we'll explain a lot more why that matters. But can you guys relate to this experience at all? Like, how many of you guys are here now and have already seen a doctor? What did they tell you? Oh, it's not showing this.
Oh yeah, where's the text?
Okay, well,
That's awkward.
This is supposed to show a really awkward distribution of a pathway.
The journey most of you guys have probably experienced between like looking stuff up on Google and then going to your doctor and then going to a radiologist and then going back to the doctor and kind of all the different stops you hit along the way before you kind of finally crash out a little bit,
So basically, it's this. If you guys can see my screen, what typically happens is, we have someone, frustrated artist, gamer, desk worker, they go, when they have wrist pain, they go to Google first, of course, and maybe Reddit, maybe ChatGPT, and it says, you may have carpal tunnel, or you may have tendonitis. You should be resting and bracing. Then they go to the doctor. The doctor says the same thing. You're like, wow, Google is right. And pain goes away, but they try to use their wrists and hands again for typing or whatever, gaming and drawing artists or playing music. The pain comes back, and then they go to see their primary care provider again, who's like, I'm not sure why. Let me refer you to a specialist. It could be a neurologist, could be a surgeon. The neurologist doesn't know what's going on because they do an EMG test and they don't really find anything. They send them back to the physical primary care doctor. He sends you to a physical therapist. And as you can tell, this goes on and on and on. And we've actually seen, you may have seen in a lot of our content, but now at this point, 10 years in, the combined caseload is around more than 3,000 individuals. And on average, I think the statistics that we've posted are, most people see around 4 to 5 doctors before they get to us, and spend around 1,200 before they get to us, because of this, for the lack of a better word, fucked up cycle that they get stuck in. We call it referral hell, right? It's a kind of like an ELO hell, but referral hell. And these are the same stories that I'm sure all of you guys and some of you guys can really relate to. Now, yes.
Yeah, definitely looking at the chat, that seems to be a lot of what's going on.
They told me they see nothing. Oh, what? And then what happened after that? Were they just like reschedule, and we'll talk more next time? Or did they just leave it at they see nothing? Because that would be really poor care. And while we wait for those responses, I want to provide you an overview before we get into the actual body of the presentation. I'm going to try to ask you guys a lot of questions, try to keep this as interactive as possible, because I think it will help you guys learn. And then 2, of course, you guys will have an opportunity to ask us questions about anything that you guys have experienced, what you're dealing with, why you're dealing with it, when Elliot's going to grow his hair out again, if I'm going to lose more weight. You can ask us anything. And then there's also going to be a special offer if you guys stay to the very end, for everyone that sticks with us through this and hopefully picks up something from the presentation. But again, now before we actually get into the meat, I wanted to ask you guys this question. How long have you guys been dealing with your problem? Like I said before, we have some data, and I want to see how well the people here match what we experience, right? So Shelly says one doc said intersection, the other didn't say anything specific, just go to hand therapy. Okay.
The intersection syndrome diagnosis would probably more correct.
I found you all. What up? Didn't tell me. I already know. Yeah. Over 2 years, more than 2 years. Yeah. Okay. Anyone else want to offer that up? And then, for the people that have already answered, what have you guys tried? It's the only bad pain, trouble gone after 3 weeks. Blue.
More than 2 years, 3 to 6 months.
3 to 6 months, yeah. 3 to 6 months. So
yeah, a lot of over 2 years. So this is the data from the troubleshooter, actually, of people that have been filling out the responses and going through that. Which I think is really cool that we can start showcasing some of the real data that we've been collecting as part of this.
But hopefully you guys can see what stands out is that more than 40% of people, or around 40% of people, are dealing with it for more than a year, right? All the other people, some 6 to 12, some 3 to 6, some 1 to 3, a few less than a month, which we love to see that people are reaching out earlier. On average, for our coaching clients, it's around 2 years, actually. So that's when, hey, I really need some more involved support. After stretching session, things improve. Reposition keyboard in a more ergonomic position. Great. Yeah, I think it's awesome that you guys there's some signs that you guys are pointing towards focusing on things that you guys can control, right? Directly control, whether it be ergonomics or your strength. And this is what this
Back
is
to our
more.
old friend.
This is more what I was suggesting that doctors are like when whether you go to urgent care or your primary care. And as you guys said, rest, ice, brace. They just said, don't see anything. Go next.
Yeah.
And then sometimes, and I am going to be posting about this tomorrow. There's even people that have gone through surgery and they actually it may reduce some of the symptoms temporarily, but the pain comes back. And we're going to explain and help you understand why that is. Why is it that why do you guys think these doctors are providing these recommendations? Why are they just saying rest? Why are they just saying ice or bracing? These are the reasons. I mean, and I want to provide some clarity. Hopefully, how much time did they spend with you? Think about this. Was it more than 5 minutes? Was it 10 minutes? Was it 15? Was it an hour and a half? I would venture to guess none of them was more than an hour. Money. And I'll explain why about this. They don't really often have incentives to learn more about the updated evidence of RSI.
They do, however, have incentives to prescribe medication and do injections and do surgery.
Exactly. Now, when I first looked into the problem of why this was happening, the first thing that I found was that a lot of the medical education curriculum was pretty limited in teaching the exact providers that are being sent out to primary care, sent out to urgent care, the first line of defense, the people that you guys go to first. They at most get, and again, only 2% of medical school curriculum on average in California for this literature review was devoted to musculoskeletal disease. Some other studies looked and basically represented it was between 2 to 15%. And at most, the curriculum, even the practical portions, they would only spend 2 to 4 weeks max. And again, these are the people that are sent out. They are the ones that are making the diagnosis that may not have even close to what an orthopedic surgeon, a physical therapist spends the 2 years of learning all this stuff and practically applying it, then spending another year in the clinic to practice this. It's no wonder why they're so behind. But the other part of this is also, if they don't remember, they actually can look up a database. They can be like, okay, hey, I'm not really sure. I need to make sure that I'm up to date. And in that database, and this is just one study, I'm sure there's other databases that are a bit more accurate, only 18% of the evidence within those databases are actually up to date and patient oriented and consistent with what we know now. So not only they're not taught well, they're also, their resources they have access to in the clinic, not great. And then you even think about, well, what types of patients do these doctors see? Hypertension, diabetes, cold, upper respiratory infections, right? Those are the things that they see like 70-80% of the time. And if they spend that much time, they again do not have the incentive to learn about this because they're not seeing them all the time. What they should be doing is just saying, wrist pain, refer to physical therapy. They shouldn't tell you or label anything to you or tell you you need injections. That's what they should be doing. Okay, and instead they provide these symptom-based solutions instead of addressing the underlying cause. Now, we're going to get into all of the science and everything that you're going to learn, but I wanted to know why you guys are here. Tell me, is it one, I have wrist pain, I wanted to know more about how I can fix it. I've been to a few doctors, we already established that, they just told me to rest. I've started to do some stretches and exercises, but the pain's still there. Or I know I need to get started on some changes, but I don't have the time, or I think it might cost too much. Not really sure. Or 5. I'm married, but hey, we can have a parasocial relationship. I'm kind of down. No, no. Anyways,
The reason
uh,
I'm here.
yeah. So okay. Oh, wow. Hey,
Oh, ow, ow.
hey, guys. Hello. Okay. So Sound Fox did endurance exercises. Yep.
It's asking about TMS.
Yeah.
You mean transcranial magnetic stimulation?
Yeah. 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 Yeah.
Yeah, I definitely think there comes a point where things get into like the severe central sensitization, fibromyalgia, where that might make sense. But I think for most cases, that's a little more, uh, it's a bit of like an extreme
Tension
measure.
myositis syndrome. Oh, we'll talk about all the syndromes. I have many stories for you guys about these syndromes. Um, yeah, we'll get into these. We'll get into the discussion of some of these. But I'm glad there's a few. 1, 5. I love you too. 3. Yeah, good. We'll teach you more about what to do. You, why everything that we preach on a regular basis will provide long-term relief. And this is the exact things that you guys will understand after today. What is actually being affected in RSI issues? What's the number one cause of wrist pain? How should we think about RSI injuries? Is there a place for bracing, ergonomics, rest, ice, medications, PRP injections, cortisone injections? We can talk about all those things. We can also talk about labels and diagnoses, whether it be fibromyalgia, tension myositis syndrome, whether it be functional neurologic disease. These are real diagnoses that neurologists sometimes prescribe. And I'll peel back the layers on why they make those diagnoses. And I have literal word for word not scripts, word for word um, statements from neurologists, from my patients, on why they prescribed and why they diagnosed them. It's hilarious. Now, then you guys are going to learn how you guys can get started, as well as some bonus strategies to recover. Elliot is going to go through a lot of these initial things, and I'll be chiming in here and there, but go ahead, Elliot.
Yeah, for you guys in the chat, we're gonna have like a formal Q&A session where we're gonna kind of go through a lot of these things. But I definitely just wanted to like make you all familiar with kind of the anatomy and what's typically going on here with the muscles. So if you take a look at this screen here, you can see all of the muscles that are involved under the skin that are responsible for doing all the movements of your wrist and hand. And the red is kind of the pain regions where they typically manifest themselves as pain. So just to clarify, for this presentation, we're mostly talking about everything from the elbow down, slightly above the elbow. You can see some of those muscles attached there. And I'm going to get into more detail of what these muscles do specifically a little bit later. But just so we're starting with the basics here, talking about tendons and ligaments and muscles and all these things, just kind of clarifying what some of that is. A tendon connects bone to muscle and is responsible for transferring force from the contractile muscle to the bone, and it is what actually causes the bone to move. A ligament connects bone to bone and is responsible for what's called passive stability, or it's just your body's passive ability for it to maintain the structure and the general architecture of joint kind of angles and things like that. So for the most part, we are going to be discussing muscles and tendons as they are the thing responsible for doing the repetitive movement that you all are probably here for. So muscles have two primary properties, and they have two muscle fibers that are responsible for those properties. Go ahead and flip the slide. We have strength and endurance. And as you can see in the picture there, you have your jacked guy out of his mind, enormous muscles. He has a lot of strength fibers, and he trains very differently than the marathon runner who has a lot of endurance fibers. And notice how their legs look completely different than this guy's leg. And as you can see, if you did like a little cross section, if you were to slice a muscle down the center and look at what those fibers look like under a microscope, it would look a lot like this for the slow twitch. It's not as much of the anaerobic muscle fibers that aren't relying on oxygen. It's more of the aerobic muscle fibers that are responsible for prolonged contractions over time, and that's why running induces more cardiovascular effects, and strength and conditioning training is usually more just about burning off the sugar in your blood for fuel. But there's very different muscle physiology that goes into both of these properties. And we'll have people come to us a lot of the time and ask us, they're like, I work out, I go to the gym, I should be strong, right? Like, why are you telling me that my muscles are weak? And we're not telling you that your muscles are weak, but they can have low endurance. There's a reason that that guy over there on the hack squat machine is not running ultra marathons. And there's a reason that those guys aren't bench pressing or deadlifting 500 pounds. Like, it's a very different training mechanism and a very different way that these muscles kind of are able to contract and the loads that they're specifically able to handle. In strength and conditioning, you have this principle that muscles adapt to the kinds of stimuli that you give them. And that is very true for the types of training that we do to handle our day-to-day tasks. So kind of moving on from there, talking about tendinopathy specifically, and this is tendon irritation. In tendinopathy used to kind of be designated as just tendinitis or tendinosis, and you have a couple other pathologies in there that involve like the tendon sheath, tenosynovitis, things like that. But for the most part, it's all the same underlying mechanism of tendon irritation that happens when the capacity for what you're able to do based on the muscles and the tendons, and they kind of adapt to the same loads together. When you don't have enough capacity for the type of activity you're trying to do, it creates little micro tears within the tissues, and it creates inflammation inside the tissues and ultimately pain. And the other symptoms are also tightness that are associated with that, and that's your muscle trying to guard in order to protect the area because it's perceived that there's pain. And when that goes on for long enough, it can become neuroplastic, central sensitization type pain, but we'll get into that a little bit later as to kind of the neurology and the brain behind it. But at a purely structural level, this is essentially what's happening now. So we've kind of gotten away from the tendinitis, tendinosis kind of nomenclature, and it's moved more onto this like spectrum diagnostic range where you see the normal tendon, what's called reactive tendinopathy. This typically happens early. It's the kind of the acute phase when things are initially getting flared up and irritated. And then if that goes on for long enough, you end up with this degeneration within the tendon. And a lot of people think that if you have degeneration with the tendon, it's just wraps for them, which is not true. There's a lot of evidence out there that shows that you can build up what's called the treat the donut, not the whole model. And so even if you do have some degeneration within the tendon, there's a lot of evidence that shows that you can still build up that tendon to be robust around it as well. So
Let's
if
quickly
anyone's
talk
told
about
you
that.
that you're kind of in this area here, it's not the end of the world.
This is it. This is the actual tendinopathy spectrum that he's referring to based on the
Yeah,
research, right? And
it's
so
slide 29.
basically it says, hey, even if you have degenerative tendons, which is really rare in wrist and hand, it's probably represents maybe 10 to 20% of our case, maybe even less, like 10% of the cases that I've seen when they go through MRI. Very few of them have degenerative tendinopathy, but even if so, it means that it's slightly thickened. And yeah, this is the donut. There's more healthy tissue, the green tissue, than the pathological tissue. So you don't have to worry. We are just focusing on loading the healthy tissue. Okay, so just to reiterate and solidify that point.
All right. So like I was saying, these are some of the symptoms that you might be feeling when you're dealing with tendinopathy. And you typically feel these at different stages, right? Like the first thing that you might feel is some tightness and stiffness. And that comes from just the muscle starting to protect itself. It senses that there's been some tissue damage there and it's just tightening down to protect itself. That might accompany some popping and clicking. That also comes with the tightness and stiffness, and that just has to do with those tight tendons like rolling over each other and the joints and the bones, which is why a lot of people start, like the first symptoms they start to talk about is just this like tight sensation and the clicking and popping. You might notice, I mean, obviously pain is one of the biggest reasons that y'all are probably here, the biggest thing that told you that something was very wrong. tenderness to the area. It might hurt to touch the area, especially the muscle that's connected to that tendon. It tends to be a lot of like really tender areas through that muscle where the muscle has become really tight and irritated. Swelling might be present as well within the tendons. There's a lot of changes that happen as that tendon is trying to heal, and the tendon actually swells up, which can kind of occupy space in places like the carpal tunnel, which we'll discuss a little bit later as to what that means and how that affects other structures in there, like nerves. A big one is loss of coordination. Like a lot of times, people will come to us, especially from like the AIM training community, where coordination matters a lot, and they'll report that they have a lot of issues not hitting their benchmarks like they used to. And then they sometimes have pain, but like that's not the primary reason that they're struggling. It's just this coordination loss. As you have inflammation inside the muscle, muscles are like they contain all these fibers, right? So it's not just one solid thing that's a muscle and it either contracts or it doesn't. They contract individually as units, all those fibers. And if you have irritated fibers, those fibers aren't going to be contracting either as quickly or as in sync with the other fibers, and that creates coordination issues. It also impacts the ability of your muscles to sense where you are in space, a concept called proprioception that sends that information back to the brain. So you can't make as good of decisions as to where to place your hand in space on the mouse if you're talking about aim training or drawing or things like that. So all of these systems get affected all the way from the muscle all the way up to the brain and back. And then if this goes on for long enough, you can actually experience weakness and kind of loss of muscle function.
And basically, just to touch a little bit on the coordination, the brain often, when we get closer to strain of the tissues, it wants to protect the area. So it will send or reduce the signaling between the brain and the actual muscle. You can think of it as like a break, like it's called inhibition. And so it won't set the signaling will be diminished or reduced, which also leads to the same problems that Elliot described, where you just can't control it well. You can't control your muscles well because your body sends less signals.
All right. Yeah. And this is the spectrum that Matt, or the kind of the flow that Matt was talking about earlier. But essentially what happens here is this concept of stress shielding when you're doing things like rest, and we'll talk about this later. You are reducing the load on the muscle, but you're not actually increasing that endurance, which kind of leads to this cycle where the tendon can move through these different stages kind of back and forth. Until obviously, like if the tendon were to completely tear, then you're kind of done. But most people are nowhere close to that.
It's actually impossible to tear your tendon from small repetitive strain
From
injuries.
small repetitive movements, yes, but if
Yeah,
you were to go like lift something heavy, then you'd be at more risk of actually doing something like that.
exactly.
This happens a lot in the Achilles, where people will have like from running long distances, and then they'll go and they'll like step in a pothole, and then it will tear the Achilles.
Yeah.
Like that's typically how that happens. But unless you're playing contact sports or doing something super
Yeah.
aggressive in that region, like this isn't going to happen just from clicking the mouse.
Which is like it should be so create some like safety, for you guys in that at worst you've just strained the tendon. There is no way that you can cause permanent damage to your wrist and hand tendons from small repetitive low load activities unless a bear appears out of your table, slashes your wrist while you're typing, or a machete shoots out of the wall, slashes your wrist. That's the
Or you're
only
hanging
way.
from a helicopter.
Right.
Captain America stunt.
Yes, exactly. Now, let's get ready for the health bar framework. Oh, actually, no.
Well, yeah, a lot of you I think might be familiar with this, but we're just gonna review it. But this is how we like to describe uh, tendon irritation and the capacity that your muscles and tendons actually have for doing repeated activity. And because we come from the gaming space, we like to describe this as a health bar, like a video game. And that represents exactly how much physical stress you can handle over time. And as you do activities, that health bar gets lower and lower and lower and lower until eventually reaches zero, at which point you're starting to do micro level irritation to the tissues, which causes the pain, the inflammation, the swelling, the tightness, all these symptoms that we just talked about. So we will discuss strategies throughout this presentation that you can use to essentially increase that health bar size and replenish the health bar as you're doing those activities. But the goal is to ultimately have more health so you can handle more. Go ahead and switch the slide. So what you can see here is like all of the things that contribute to losing health. Things like poor posture. If you start with bad ergonomics, if you have even genetic predisposition, a lot of people are like, oh, well, that guy plays just as much as I do, and he's got the same setup that I do. Why do I have wrist pain and he doesn't? That is a question we get all the time. And sometimes it's just genetics. Like different people have different distributions of endurance muscle fibers just genetically. There's a reason that some people are great long distance runners naturally, and some people are great power lifters naturally. It has nothing to do with like, I mean, it definitely has a lot to do with how long they train, but that starting baseline and their ability to build endurance is genetically different. So there's a huge component of that, but you can overcome that with training, is our whole point with this. And then the repeated actions obviously are going to have you lose HP as you go on over time. Next slide really highlights the importance of what you can do to level that playing field, and that's the endurance training. And that's what essentially the crux of our philosophy is built on, that you can handle almost anything. You can climb mountains, you can jump off of buildings, with a parachute, obviously. You can run marathons. You can do all of these things. You can type at your computer for 10 hours a day. You can play video games for 16 hours a day if you're grinding old school RuneScape. You can do all of that if you properly train your tendons. So I just want to make that really clear that this is really the biggest component of things you can do to balance that playing field. And as you'll notice, stretching, bracing, rest, things like that are on there too. Like they have their place, but it's very fractional compared to this endurance training concept. And so there's essentially two different types of endurance. You have general endurance training and you have specific endurance. If we're going to go back to like the marathon training analogy, yes, if you're going to train for a marathon, you should be in the gym doing endurance exercises. This is with dumbbells or exercise machines, things like that, in order to build up the capacity of those muscles with the progressive overload principle, where you're doing a heavier weight than what you would normally be doing with your activity. For us in our training programs, we typically use a dumbbell that's a fraction of your body weight and slowly trying to work that up heavier and heavier. But nobody is pressing keys on a keyboard that weigh 8 pounds, but we're training the muscles with a lightweight for high reps to build, to stimulate the growth of those endurance fibers. And then there's the specific endurance, which is the actual act of doing whatever it is you do for your activity, whether it be hobby or work, that requires the use of these small muscles that need this endurance. And you cannot do either one of these in isolation and expect to get back to 100%, because they both serve a different purpose. There's a reason that soccer players have time in the gym, and they also have practice and scrims, and they're actually playing games to get their endurance to the level it needs to be so they can perform at their best when it comes time for them to play real matches. They don't just practice in the weight room and expect to be good on the soccer field out, or just doing drills. They actually have to play the game for an extended period of time so they can handle that load. And the same exact thing applies to whatever craft you do, whatever you do for work, the musical instrument you play, the peripheral you use for gaming. All of these things are real world activities that require this property of endurance, this specific endurance, and you have to be building it up alongside that general endurance. So yeah, these are the wrist pain patterns we discussed earlier, and these are where people typically report pain. And these can kind of be boiled down into four general muscle groups, which we'll kind of discuss next here. But all of these pain regions have an associated muscle or muscle group that is causing the pain, that's responsible for the actions that you're doing. So we move on here to the I think the slide actually just kind of rehashes that point. Let's go to the extents or the flexors.
Oh, the flexors.
Next slide.
Okay. Yeah.
Okay, so this is the flexor muscle group, and this is responsible for gripping your mouse, holding your phone, holding that controller, pinching the stylus to move it around, flexing. It's responsible for this motion here: flexion of the fingers, flexion of the wrist, flexion of the forearm muscles here, and a little bit of flexion at the elbow too, but that's not its primary action at all. So anything responsible for this, these are the muscles involved. They all start right above the elbow. They go down all the way through the forearm, and then the tendons at the wrist connect to the fingers and are responsible for moving the fingers. You have specific muscles in this group that are also responsible for like side-to-side motion of the hand like this. So a lot of aim trainers that are flicking side to side will end up with issues here, especially that flexor carpi ulnaris, that red muscle that's kind of there, is a big issue for people that move the mouse aggressively side to side for whatever reason. The extensor group is going to be on the other side of the hand. So these muscles also start above the elbow. They run all the way down through the forearm, and then they turn into tendons kind of around the wrist, and then go down into the fingers and are responsible for finger extension like this, wrist extension. And these muscles are irritated when you have to do things like when you click. So when you're clicking, you're not just clicking down, you're also pulling back. So this gets super irritated when you're clicking. Also, left and right movement of the mouse, because those muscles are responsible for that, what's called radial and ulnar deviation. They work in concert with the flexors. And a lot of times this muscle group is a lot weaker than your flexors. Everything in the human body is kind of designed for flexion. Like you're designed to come down into this position to grab things, not really designed to go into extension to be very strong here. So extensors are oftentimes have less endurance and are a lot less strong than the flexor group. So these muscles get irritated a lot quicker with repetitive actions because they don't typically have the same capacity and endurance that the flexors have. So yeah, let's move on from that. Next, you have the thumb flexors, and these muscles are really responsible for pinching. So definitely anybody holding a stylus, anyone playing a console game with a controller that has a joystick on it, is going to be using these thumb flexors a lot. Pinching the side of the mouse, gripping that mouse tightly with the thumb, is going to be very, yeah, there's a little demonstration from Matt. Yep. All of these movements associated with kind of flexing that thumb downwards. Playing instrument, guitar is a big one. Holding that pick up and down, or if you're finger strumming, very intensive on the thumb flexors there. And these muscles are responsible for that thumb flexion, that movement called opposition, where that thumb comes all the way across, curling the thumb downwards like this. All of these movements are kind of responsible for irritating these muscles. And thumb extensors are on the other side here. And these are really responsible for extending the thumb, pulling it backwards. A lot of these get irritated a lot with different types of grip styles on the mouse. So if you have more of like a claw grip and you're kind of pulling back like this, it irritates it through here. Musicians deal with this a lot. A lot of drummers deal with this from going up and down like this. That pulling up of the wrist in this kind of neutral position really irritates those thumb extensors. Artists deal with this a lot as well, also from gripping that stylus and kind of pulling it in like this. Anything that involves extension at this thumb here repeatedly is going to irritate these muscles. So based on our data, this is just from the troubleshooter again, this is what people are most often dealing with as part of kind of these repetitive strain injuries that we see here. And as you can see, wrist flexors is an enormous distribution of this pie chart here. Wrist extensors, also an enormous distribution, and everything else distributed a little bit less. Thumb extensors also there, and thumb flexors, and then everything else outside of that is a little bit more nuanced and niche. But like I said, those are the four main groups that you can kind of boil all of this down to. And if you'll notice, I included at the bottom here some of the nerve symptom distribution that we see. With the ulnar nerve being one of the biggest nerves that are affected, and we'll get a little bit more into nerves here in a minute. But this indicates that these muscle groups are also irritating and compressing on nerves. So there's a really interesting distribution of how the muscles that are tight are impacting the nerves and the symptoms that they're causing that are causing people to have issues. When you say irritate these muscles, how does that change the effect on the tendons itself? So you got to think about tendons and muscles as essentially the same unit. It's called the musculotendinous unit, and they both respond to the same stimuli and the same stress. So if you're consistently stressing a tendon that is connected to a muscle, and that muscle doesn't have enough endurance, that tendon is having to pick up the slack for the muscle that doesn't have the endurance, and it's irritating at essentially the same rate. Tendons also increase their intracellular matrix, their capacity for handling stress at the same rate that muscles do. This is why, like, okay, so I use this example sometimes. There's a thing called BFR, blood flow restriction training. It's essentially you use a tourniquet on your muscle that keeps the blood in that muscle longer, and it actually stimulates growth hormone, so the muscle will get bigger even when all you're doing is just like opening and closing your hand and you're not actually applying a weight to it. And there's a lot of research that shows that you can increase the size of the muscle through this little like biohack essentially. So the muscle actually does get stronger and it increases in size. And they use it a lot in like rehab for people that are post-surgical and literally can't put any stress on the bones, but they want them to preserve some muscle mass. But when you do this, you are not actually applying a load to the tendon. So the tendon is not getting stronger. So if you were, there's people that have like tried experiments on this, how big can I get? How strong can I get just doing BFR training? And what they find is that those people end up tearing their tendons because the tendons don't have the same capacity as the muscle, that so the muscle can contract and like essentially like let's say bicep curl. You can bicep curl 100 pounds with the muscle. You're capable, you're that strong and able to do it, but the tendon doesn't have 100 pounds of capacity
Yep.
and able to actually lift that weight. So what ends up happening is the tendon tears, even though the muscle can lift that weight. So you have to think about muscles and tendons responding to the same stimuli and the same load, and they need to be working together in order to move and create the action at the joints and the bones.
Yep. Tendons need load
Tendons
to
need
get
load.
strong.
That like there's no way around
They
that
need
very
that.
very simple fact.
They,
People have tried. People have tried millions of things to try to get around that.
yeah.
You have to apply a load for tendons and muscles to function properly and be stronger and healthy. So yeah, endurance helps you do more. You're able to increase the size of that health bar that we talked about earlier through endurance training. And a lot of us live sedentary lives and aren't doing a lot of endurance training. And as you get older, that starts to catch up with you. And that health bar shrinks and shrinks and shrinks and shrinks the more sedentary you become as life gets more chaotic and hectic. It has like it doesn't have a lot to do with your actual physical age, although like once you start to get into like the elderly years, it does. You start to lose muscle mass at an accelerated rate. But for most of the people here that are working and young, and it's usually the creep of life that makes us more and more sedentary, which decreases the size of that health bar over time. So you have to kind of be fighting against that in order to maintain the size and not to even say increase the size.
So let's stop here a little bit because I wanted to ask you guys this question, right? Does this graph make sense, right? As let's say you're 18, you spend 8 hours a day on your PC. Let's say this bar right here represents 1,000 HP, right? And you do 8 hours of work on the PC, and then you go home and you game 2 hours. That takes 800 health. Then you just keep that lifestyle up. Does your health bar stay the same? Probably not, right? It will go down just like this. In 19, you'll be here. 20, you'll be here. If you just sit in front of the PC for a majority of the day, you aren't exercising, you aren't walking on a regular basis, you aren't specifically working on your wrist and hand. It's also why, hey, like when we're maybe, this could be when you're in your 20s, this could be when you're 25. Everyone's individual anatomy is different, but there will be a time if you don't do anything that maybe you have a spike of activity. I have to finish a work sprint, or I decided to play this game 10 hours, 3 days in a row. That will probably exceed your capacity when you're here. This is why these types of injuries occur. Because you are deconditioning if you don't do anything. And you're applying the same stress every single year. A lot of the times people will say, well, I didn't have pain before. That doesn't mean that, you were reducing your risk of injury. Your risk of injury was just staying the same. It's getting lower. So let's.
Yeah, there's a question in the chat from Shelly about eccentric exercises. And eccentric exercises are actually really important if you're returning to what's called plyometric activity. So that's actually more of the strength component. So like a lot of athletes, for instance, like will develop these tendinopathies that are associated with like basketball players, for instance, repeated jumping. That's a plyometric exercise. That actually has more to do with the property of strength, muscle strength, than it does endurance. And that's where eccentrics are really important. Eccentric exercises are like the best way to build strength in a muscle. So that's why those exercises are so important for highly athletic populations that are taking that plyometric force through their tendons. But most of us here are discussing issues that are related to kind of small repeated movements and not generally a lot of like plyometric force, which is why most of our philosophy is more related to this type of endurance training. Alrighty, so this is the nervous system, a quick diagram. I'm just going to explain what some of these things are. So in the skin, you have these receptors and you have nerves that connect to those receptors. And those receptors go up into the spinal cord and eventually to the brain. And they let your brain know what's going on when you're touching something. And then you also have nerves coming from the brain that go down the spinal cord and into the muscles. And those nerves are responsible for making the muscles contract. And this whole loop talks to each other. So information from the muscles is also going back up via sensory receptors to let your body know, or let your brain know where your body is in space. And it's this entire loop that gets information back and forth from the brain to both the skin for sensation and the muscles for movement. So that's why you see the sensory and the motor neurons there. And I just wanted to kind of explain that's the way that nerves essentially work in the body. Which will be relevant to what we're going to discuss next, which is nerve symptoms that people have. And just before I get into this, I want to like make very clear that nerve symptoms that are things like numbness, burning, tingling, that like TV static feeling, they always exist downstream from where a nerve is compressed. Nerves are very bloodthirsty tissues. They need a lot of blood to function. So if any compression happens to a nerve, it affects the nerve's ability to actually maintain what's called its electrochemical gradient because it's getting its blood supply cut off. So that's why, like, if you rest your elbow at the wrong spot on your armrest for a little too long, you start to get numbness and tingling down through the pinky and the ring finger there because you're compressing that ulnar nerve. And the same thing can happen when muscles get tight, as muscles will pinch on that nerve, and it will always send symptoms downstream, which is a big thing we preach a lot when we're talking about carpal tunnel. Like people will say, hey, I have carpal tunnel and I have numbness and tingling kind of up through here. It's like that cannot be coming from the carpal tunnel, because any carpal tunnel symptoms have to be here and down only. So you can't have a nerve compression that takes place above the site of compression. And that being said, there's three major nerves that are in the forearm that are responsible for the sensory regions that you see here. So if you have symptoms kind of through that index, middle, and thumb on the palm side, that's your median nerve. Through the pinky and the index, or the ring finger on the outer side of your palm, that's going to be the ulnar nerve, and then the radial nerve will be on what's highlighted there in the blue, that thumb, middle, and index finger on the back side. So those are the three major nerves that kind of innervate the skin, and those are sensory nerves we're talking about here. When they get compressed, they can present with symptoms in these spots here. Yo, Blue, thanks for the $4.99. Let's go. So what happens when these nerves get compressed? First, you'll feel that numbness and tingling, and then the burning sensation and pain that kind of comes with that. But if the nerve compression goes on for long enough, and when I mean long enough, I mean months to years, you'll actually start to see muscle wasting here. We don't see a lot of this happen. This is definitely something that takes place as people get much older, but it is possible if a nerve is compressed for long enough. Typically, this comes from fibrotic changes or things like trauma. But it is possible for you to have muscle wasting if a nerve is compressed long enough, because those nerves are also responsible for innervating the muscles. So those are the two types of nerve symptoms that you can have. And the most common areas for these nerves to get compressed, we're just going to go through each one of these nerves one by one. So the ulnar nerve, go ahead and flip the slide,
Yeah,
Matt.
I'm sorry.
All good. That ulnar nerve gets compressed at what's called the cubital tunnel at the elbow, typically, or it can also get compressed down in the wrist at what's called Guyon's canal. And that's going to be on the outside of the wrist there. And that can actually happen from just resting your palm on the edge of your desk. A lot of people that have their, like, the edge of their desk on their palm like this will end up with some Guyon canal palsy, which is an irritation of the nerve, or a compression of the nerve as a palsy. But most often this happens at the cubital tunnel here on the inside of the elbow. And as you guys can see there, all of those flexor muscles that we talked about earlier kind of sandwich that nerve there at the ulnar tunnel. So when these muscles have low endurance and you're overusing them and they get tight and irritated and maybe a little bit swollen, they will compress on that nerve and start to cause symptoms that come all the way down into the hand and present in those last two fingers. So that being said, the the underlying root cause, we talked about symptoms versus root cause earlier. The underlying cause of most cubital tunnel syndrome, and there's other kinds of cubital tunnel syndrome that can come from, like, just deformities in the elbow, or trauma that causes severe laxity, or even like something as crazy as a tumor. But I don't want you guys like jumping to those conclusions. When you hear hoofbeats, it's best to think horse, not zebra. 99% of the time, these cubital tunnel symptoms are coming from tight muscles in the forearm from overuse.
Mm-hmm.
So that's the main mechanism there. And then also we have the radial tunnel here, and this is the radial nerve that innervates the kind of the back of the hand here that we talked about earlier. So that muscle, it dives under the extensor mass, also what's called that supinator muscle. And these are muscles on the backside of the forearm that are responsible for that extension movement and kind of rotation side to side and rotation of the wrist like this. And those muscles can pinch on that radial nerve, causing those symptoms there as well. And then finally, we're going to talk about the dreaded median nerve, the carpal tunnel. And we're going to do a much deeper dive into carpal tunnel here. But that is typically where that median nerve gets compressed, is at that carpal tunnel space. And I'm going to very thoroughly describe what that is. But
Let's take a quick pause here.
yeah,
I've answered a few questions in the chat. It's interesting, right? One of the more recent, I think Vic, who I think I worked with, mentioned that, hey, there's this researcher out of UC Davis, Keith Barr, who looked into isometric protocols. Also, Ebony Rio has looked into a lot of those things. We've definitely looked into a lot of research. I might have even seen Keith Barr's research, and he said that, isometrics are better for prevention and pain relief than eccentrics because they squeeze out the inflammation. I don't think that the physiology is that they're squeezing out inflammation. Pain is not. They've even proven this, that pain from the tendons is not directly associated with the inflammation. It's still up in the air, and the best evidence supports the idea that pain is coming from the cells. It's a cellular response that's causing the pain perception or pain experience, rather than the inflammatory cytokines in the post-collagen tearing that's leading to small amounts of inflammation that's causing pain. It's not that. They've shown that in the research that that's not the proven cause. And so the reason why we've tried isometrics, we've tried heavy slow loading, we've tried plyometric based approaches, and what we found that is the best support that leads to the best outcomes is early isometrics, using isometrics for pain relief, the 3 times 45 seconds at 60-70%, that max voluntary contraction, as well as resting around 30 to 40 seconds between those sets. That helps to provide pain relief for up to 1 to 2 hours. And we typically use isometrics during that 1 to 4 to 5 weeks, depending on the individual's acuity. If it's really bad, it can be helpful to load the tendon really lightly with that in the early stages. But in most cases, tendons aren't that weak. There's very few people that have such weak wrist and hand tendons. And most of the elevated, super high pain is associated with fear. It's actually really interesting because people think that high pain equals high damage, and we'll clarify this later on. But anyways, you know, that was just a quick preview, I guess, an open window into how we think, what types of research and protocols we have integrated in, not only our app but also all of our work. Now, let's get into carpal tunnel. What's up? Let's get into carpal tunnel syndrome, because this is the number one thing that everyone talks about all the damn time. I have carpal tunnel syndrome. I was diagnosed with carpal tunnel syndrome. I got carpal tunnel release surgery. Is all wrist pain carpal tunnel?
Matt, turn your mic up.
It keeps turning back down, so I'm just my Elgato's cut.
Turn it up. Woo. Is all wrist pain carpal tunnel? Let's hear it, chat. No, thank you. There we go.
There we go. We got a smile.
For some reason, like carpal tunnel is the only, like, has become synonymous with the word wrist pain. Like nobody knows, unless you've been through it and have been in this rabbit hole for a while. Nobody else knows any of the other diagnoses that can cause wrist pain outside of carpal tunnel.
No.
So we're going to discuss here what carpal tunnel is and it is not, and hopefully this will make a whole lot more sense for you guys. If for no other reason than you can tell people that they don't have carpal tunnel syndrome.
Yes, be our advocates. Go tell people. Hold up signs.
So carpal tunnel is a lot like a sandwich. So the carpal tunnel is it's got bones on the bottom. The bottom of the sandwich is the actual carpal bones, and those are the bones of your hand in your palm, where they meet the bones of your forearm. So you have like two rows of bones that they sit like a little like U. So the bottom of this sandwich are the bones. And then above that, you have the meat, which is the flexor muscle tendons, basically. And there's also the thumb flexor muscles and their associated tendons. At the point of the carpal tunnel, it's all tendon, really. There's not really any muscle, like muscle bellies that pass through that area. It's all the tendons that pass through that carpal tunnel. And then on top of those tendons, kind of sandwiched in between them, you have the cheese, which is the nerves. And like I mentioned earlier, nerves don't like being compressed. So there's not a whole lot of room in there for them to kind of move around freely. So it's kind of a tight space. So as soon as you start to have any kind of space reduction in that area, they start to scream pretty fast and you get that numbness and tingling. And those are the primary signs of carpal tunnel. Like people will say, oh, I have carpal tunnel, but I don't have numbness and tingling. And it's like, that's an immediate, like, no, you just have tendon irritation. It's just the tendons that are in pain. Numbness and tingling is pretty par and parcel for carpal tunnel, and part of almost all the diagnostic criteria. And the top part of that carpal tunnel, that top piece of bread, is the carpal tunnel ligament. And this is one of the most like misrepresented structures in all of wrist pain medicine history. Like this structure gets blamed for so much when it's not the problem at all. This carpal tunnel ligament connects the each side of those arches of bones together, and it kind of like forms the roof and holds them together so your hand doesn't splay out flat when you put it down on something or put your weight on it. If we go to the next slide here, it shows the carpal tunnel ligament a little bit more clearly.
Yeah, hold up. Boom.
Yeah. So there's the carpal tunnel ligament, kind of making the roof of that sandwich. As you can see there, you can see the nerve, and then the tendons, and then the bones on the bottom. So that true carpal tunnel syndrome is when this ligament actually becomes thicker and starts to compress on that nerve. Do we have any guesses as to how long that takes in the chat?
How long does it take for the carpal tunnel ligament to thicken? Let's see on
Any
this
guesses?
episode of carpal tunnel
Is it
syndrome.
weeks? Is it months? Is it years? 5 years?
Wow.
5 years?
50
50
years.
years.
Oh my god.
I mean, 50 years is actually a better answer.
Oh.
Because if we flip the slide here, the carpal tunnel only thickens about 0.02 millimeters per year with consistent stress applied to it. And you need to see about 20 to 30% thicker ligament for that to actually be clinically relevant, which is about 0.3 to 6 millimeters of the actual growth there. And just to put that in perspective for you guys, it would take 5 years of consistent loading just to reach a 0.1 millimeter increase for it to be detectable on this these ultrasound scans. So yeah, this takes decades, not any, like 50 years is a closer assessment, probably more like 20 to 30. But for you to actually have a thickened carpal tunnel ligament to the point where you need the surgery, and that's your only option for fixing this.
That's what they do. They literally cut the ligaments. They cut the. It's like they eat a sandwich. Like, here's your sandwich now. You don't have the top part of your bread.
Right.
Good luck.
They cut the ligament. They put you in a brace. You have to have the stitches, and you wait for it to heal back looser, essentially.
And
But
guess
it
what?
does nothing to fix the underlying problem that got you in that position in the first place, which is the tight tendons.
Which is insane because I was just looking up all the carpal tunnel surgery research. Did you know the official recommendation post surgery is that they don't need to do rehab? The officials, like, they just say you just need to rest a certain amount of time. You can get back to work.
Yeah.
That's what the official recommendation is from the orthopedic surgery board.
Because what got you into that position in the first place surely won't get you back into that position after, and then you just cut the ligament. Like, it just doesn't make any sense.
Right? And so what actually is the problem, right? Is, well, we can talk about this first, I guess.
Yeah. So in order to properly diagnose carpal tunnel, we'll stay on. We'll keep entertaining the thought that this could be carpal tunnel syndrome, the thickening of that ligament. The test, the primary test that a lot of doctors just do this test and call it a day, is that Phelan's test where
That's
you kind
it.
of put your back of your palms together, and that decreases that space in there. But that's not even specific enough for isolating that ligament being the cause. It just means that you have decreased space in the carpal tunnel, which if you have numbness and tingling of the fingers that are associated with the median nerve, like that's a no-brainer. Like you shouldn't, like, yes, of course. And then ultrasound. If you go back one slide, you can see the ultrasound. This is kind of your gold standard for determining what is actually going on in the carpal tunnel space there. And that will actually show tendons that are inflamed and actually thicker, which, spoilers, but it will also show if that carpal tunnel ligament is actually thickening in the problem. And if that carpal tunnel is thickening in the problem, then by all means, like, get the surgery. But you should probably try rehab first.
Yeah,
because there might be a considerable amount of the issue that's coming from the tendons.
Exactly.
But that being said, an ultrasound should absolutely, an MRI will achieve the same result as well, but they don't typically order MRIs for wrists. An ultrasound is a really easy way to see what's going on there. These are the diagnostic criteria for proper carpal tunnel syndrome. These, like, you have to have numbness and tingling exclusively in the median nerve territory. So if you have symptoms anywhere else, it's not carpal tunnel. Numbness at night. At night, things swell up more because you're not using your hands and it's not pumping some of that inflammation out of the area. So it actually has time for that inflammation to settle in, which makes things thicker in that space, which compresses the nerve more. So a lot of people do have nighttime numbness. Any muscle atrophy is definitely a big red flag. So if you have, like, decreased muscle wasting of any of the muscles, like one side or the other, it's like significantly reduced and you're like dropping things and not able to like, that's a big red flag. Definitely get that checked.
But let's just stop there. Like, that's like never the case. Like, we rarely see any real
I've not seen it.
atrophy.
I haven't. I
I
don't think I've seen
literally
it.
have not seen any real thenar atrophy. None of these symptoms are ever.
I used to see it in the hand
Present.
therapy clinic I worked in, and we'd have like people post up and things like
Oh,
that,
for
like after
sure.
car accidents and stuff like that.
Exactly.
I used to
Yeah.
see it all the time then, but I've not seen it from just pure repetitive strain injury. Um, and then they should be doing endurance testing. You need to know like what the capacity of those muscles and tendons that are going through that space actually are. If you don't know that, how do you know what is the real root cause here? And we'll get a little more into that later. But these are some of the questions that your doctor should be asking as well. What is your pain level at rest? What is your pain level with activity? Like, what is stopping you from being able to continue doing your activity? Is it the pain? Is it the numbness? Like how actually is this symptoms, how do the symptoms behave? Um, and does the pain improve when you do different things? Does stretching it make it better? Does icing it make it better? Like what actually helps, what palliates it is a big diagnostic clue as to what is causing it. Um, and is there stiffness associated with it, kind of like waking up in the morning, um, as well?
Yeah, there's actually a lot more questions that could be asked. Like,
Right, but
you
these are
know,
the basics.
these are
Like,
just the basics. And so, obviously in our evaluations and our app, we get into a lot more depth because we need to understand how the pain behaves so that we can be confident in what tissues might be involved.
all right. So now that we've discussed that true carpal tunnel syndrome, let's talk about what can cause carpal tunnel symptoms. And this is not necessarily the thickening of that ligament. This is tightness, inflammation of those tendons compressing on that nerve. Any part of that sandwich can cause problems here. Even if you had like a deformity of the bones, it could cause problems there, but that's also not a repetitive strain injury. That's more of a trauma situation. Um, but the most likely culprit, the thing that's actually making you do the movement in your hands, is these tendons. So if you're doing repeated movements with your hands, it's 99.999% probably the cause that you have tightness and irritation in these tendons compressing that nerve. Um,
And
so now that we've gotten that out of the way,
and basically, it's again that same idea of the health bar. When there's too much stress on the tendon cells, they get irritated and they become reactive. You remember the continuum that Elliot shared. And when it becomes reactive, water goes into the cell. Proteoglycans, which are little proteins that go into the cell, that's what causes it to become more thick temporarily. Okay? Temporarily. Should I say it again? Temporarily.
hit them with a side cam.
Temporarily. 4 times. Okay? That's why it can cause these transient symptoms. And it can cause physicians that may not perform a really thorough assessment to just say, well, it must be carpal tunnel syndrome when, yeah, it's transient irritation of the nerve caused by the tendons. And they can just figure that out by asking what causes the pain. Oh, I use my wrist and hand a lot. Oh, makes sense. Probably because you're repeatedly putting stress on the tendons. The tendons thicken temporarily and cause nerve symptoms. And if they just ask a little bit more those questions, oh, does the numbness go away? Yes, it does. Okay, good. Especially after activity, after a while, yeah, it'll get better because the reactive tendons will reduce in size again. So again, these are all really important things to recognize. And I want to share a quick story, and we'll go through a few other stories about some of the patients that we worked with. This is Maddie. For those that are AIM trainers, I still work with Maddie on a regular basis, but just for prevention and to help him push for his continued high scores. And basically, he had dealt with pretty bad pain after winning a tournament, and it actually affected him during the tournament because he played a lot. He had aching that was at 4 to 5 out of 10 after 2 to 3 hours of aim training, stiffness, misclicked. And what we focused on was, hey, his endurance was actually not great. 33% of it was normal. He wasn't really intentionally thinking about his schedule, meaning He would just play all at once, wouldn't warm up, wouldn't take breaks, wouldn't regularly exercise, and would just slam his wrist, cause the tendons to get irritated, not allow it to deload or slightly recover over time. And so we addressed those things. We improved his endurance. It took us some time, but now, this is a while ago. It's pain-free. He keeps winning. He literally keeps winning. It took us about 4 weeks to get him to 70% improvement, 4 months to get him full 95. And this is, what we've done with many people. Right? We've, as I've mentioned, 3,000 plus people that we've seen through our app and with our coaching that we've helped them with. When we address the right thing, results follow. When you address the underlying cause with a good evaluation, with the right questions, results will follow. Now, let's go over what the 3 most common causes. What do you guys think are the 3 most common causes of wrist pain? Drop it in the chat. Based on your understanding of the health bar now, what do you guys think? What causes wrist pain?
Here, chat.
Yeah, overuse, too weak, bad lifestyle. Chatting.
Chat causes wrist pain.
Chat causes wrist pain. It does. When you chat a lot.
Compressed nerve, yes, sometimes.
Yeah, sometimes. Well, we're saying more causes rather than the source, right? Rather than the source of the pain. Because, yeah, the nerve can sometimes be the cause. The tendons are majority of the time the cause. Sometimes the nerve can get irritated at the chest, at the elbow. Number 1 is the health bar. Think about the health bar, right? It's the endurance of these specific muscles that we're using. If it's the palm side, the flexors that we discussed, you want to build the endurance of the muscles and the tendons so they can handle the stress. If you don't have enough capacity, then those tendons and those muscles will get irritated, causing the pain. If you lift your fingers up a lot, if you draw a lot, it's the same idea. The thumb will get irritated. The top of the fingers will get irritated. You have to build up the capacity so you can handle the stress that's applied onto it. And this is mostly the problem, like one of the largest causes of wrist pain that we've seen, because people don't focus on endurance. People only do stretches. People have rested. They've tried bracing. They've done these cycles where they haven't done much. And what do you think happens when you just rest, when you just brace, when you just take medications? Do your muscles get stronger? No.
Spoiler.
No, they don't. So, they don't, right? And that's why these problems happen. But you layer on the fact that you are deconditioned with the idea that you do too much, too quickly, too soon. Right? And what I mean by that is, let's use an example of first a gamer, and then 2 like a software engineer, desk worker, analyst, etc. The gamer that plays way too much because a patch is released or a new game comes out, they play 8 hours 3 times for 3 days in a row, maybe like 10 hours 3 days in a row, when on average they normally play like 4 hours. Too much, too quickly, too soon, it strains their tendons and they get their tendons irritated. And sometimes it can be associated with these other factors like posture, ergonomics. Again, those lead to how quickly you lose HP over time, but the size of the health bar is what's most important. And if you do too much, you'll always exceed it. You can sit in perfect posture, but sit in perfect posture and type for 24 hours straight, your wrists are probably going to hurt. Okay? Now, to provide an example for, let's say, like a software engineer, let's give a good example where they don't do too much too quickly, right? Let's say the engineer, they on day 1 they have to do 5 hours of work on that day, but on the second day they don't have that much work. Third day they have to finish a work sprint. They happen to finish it in 7 to 8 hours, but the weekend comes, so they get a rest, and they kind of repeat that cycle. Some days more, some days less. They're just lucky that their work sprint doesn't spam them on a few days in a row where they have to cram, finish the project. He's lucky, this person. They're progressively loading, so their specific endurance is increasing. They can maybe handle more over time if it continues to go like this. But life is never this straightforward, right? We're not that lucky all the time. In reality, sometimes we have these high loads, we have a chance to deload, but maybe through our work or maybe through gaming or in what we do on a regular basis, we just push 3 days in a row, high 10 to 12-hour days, because we need to finish something. And if we don't have the capacity, if you think of these as stress units, then it'll get into the red section. It'll cause irritation of those tendons and muscles. So what's important is managing this, managing your load. If you can take more breaks throughout the day, but if you also just build your buffer to be so high, you can handle all of these larger volumes of work or wrist and hand activity without risk of irritating it. And then we can talk about what happens afterwards, right? What typically happens in most people is that when you feel pain, what's the first thing that you guys do? Do you guys, stop? You look at Google, people tell you to rest and you don't do anything, or you wake up, you're like, oh, I just did too much. I'm gonna still move because I know movement is healthy, and you get back to using your wrist and hand. What's most likely, or what's more common? What have you done when you feel an increase in pain? 6 to 7 out of 10 is sharp. Will you be afraid? Will you feel confident that you can still move? Let me know in the chat. What happens when you feel more pain? What is a typical response, and maybe how have you responded? Pause for a bit, stop, cry, get frustrated, all of those things. Yep. I cry too. So yeah, it's normal, right? We read something. The most common is we go and read, we go to Reddit, we go to Google, we look up something, we are just told to rest, so we stop activity. We avoid, right? We think that if we keep going, it will cause further damage that you can't really control, or that will cause that you feel like will really severely limit you. But in reality, the actual approach is first to understand more about pain. And what I mean by that is pain, everyone needs to know this, is never a reflection of the state of the tissues. It is always about protection. And so what I mean by that is, if any of you have ever sprained your ankle, how many people have sprained their ankle in the chat? Drop a Y for yes, I have. And then after the Y, tell me, how long did it take for the pain to go away? At least 30 times. Basketball, yep. I've rolled my ankle so many times. How long did it take for the pain to go away? Let me know. Let's see. A couple weeks, yes. 3 to 4 weeks for moderate ones. A week or two, yep. What else? And then while you guys are waiting, everyone pinch your earlobe as hard as you can until you feel pain. Ouch. That hurts, okay? So we have these responses a couple weeks, a week or two, more mild sprains, or a few days actually. But when you look at the ligament under MRI or ultrasound, it takes 12 weeks for the ligament to heal, okay? Pain never tells us about the state of the tissues. It's always about protection, okay? And now, we all pinched our earlobes. It hurt. Ow! You've in no way damaged your earlobe. This never happened, right? This is the ankle sprain. Understanding that pain doesn't tell us. But because pain is an experience, you can think of it like a processing system. It takes information all around us. And if it's a signal that signals more danger, it will increase our pain. And what how do you think fear, or I think that this is going to cause, permanent damage, or I will no longer be able to work anymore, or I really need to work and I can't use my wrist and hand, that increases the feeling of danger. And then that will cause your brain to process those signals to increase pain. But when we understand pain, when we know, hey, well, I know pain doesn't always tell me what's going on. In fact, I know sometimes it can just be sensitized because I'm afraid. I can actually feel confident in continuing to go because I know these small, low load activities will never cause permanent damage for my wrist and hand. So I can start moving a little bit. That reduces the signals of danger around you, and that will reduce pain. Oops, this should be down. And so this is a really, really famous study. Okay, this study right here.
Turn your mic up real quick.
This is in the British Medical Journal. Okay, this guy, he shows up to the ER in a boot, and a huge nail is through his boot right where his first toe is, and he's screaming, he's in pain. This is in the actual case study in the British Medical Journal, and he asked for a really strong pain medication. They give it to him. They give him strong opioids. They give him all of this medication, and he still has 10 out of 10 pain. He feels bad, and then they use a saw. They cut off the boot. They take out the boot, and guess where the nail is? The nail is between the first and second toe. It never touched his skin. It just went through the boot. But because he thought that it hit him in his toe, all this damage, he created the experience of pain. This is one of the most interesting studies that was released pretty early on in like 1930s or something, 1940s, that showed that maybe pain doesn't tell us what our tissues are doing. Now,
Bro had to be so embarrassed.
yeah, exactly. Now, what are the things that we can do, right? If these are the causes, what do you think we would have to do to address those things? But, Elliot can speak a little bit more about, what are typical things that are provided and why they may or may not work.
Yeah, so we had some questions about ice in the chat, and we're going to get into all of these things that you probably have tried. I would guess that many of these things you out there have at least tried one of them. And these are often the things that the doctors prescribe as soon as you report pain to them. So the first one is the most intuitive. Obviously, hey, it hurts when I do that. I'm just going to stop doing that. And alongside that comes bracing. It's like, oh, well, I need a little bit more support because my wrist hurts when I do this thing. And if I support it, then I have to do less with my tissues, and therefore it will get better. And this will work if you plan on not doing that volume ever again. It's like, oh, well, yeah, I don't need to actually type for 15 hours a day. So, yeah, let me just wear this brace or stop doing that, and then I'll be fine. But if you do have pain after typing for 1 or 2 hours and you just start bracing it and resting it and not doing that anymore, you're not actually progressing or preparing those tissues to be able to handle even that. Go back, Matt. This concept of stress shielding, and as you can see, there's a big shield over the muscles. When you shield your muscles and tendons from load, they only get weaker and will be weaker when you try to go use them again. So temporarily, it solves the problem. It's like, okay, yeah, that feels better when I stop doing that and just rest it. But as soon as you go back to doing it, all you're doing is going to re-irritate those tissues because now they're not properly prepared to handle the load that you put on them. So yeah, this reduced load, what is better to do instead of complete rest is just reducing your load. And this is kind of where understanding how much capacity you have for activity and really being meticulous about tracking this is really helpful. Say that it hurts after 4 hours of using the mouse, right? And you reduce that down to, let's say, 3 hours of using the mouse. It's like, okay, I can handle this without pain. And then you slowly start building your way up from there. while you're doing the endurance exercises. We had a question earlier. It's like, can't you just do specific endurance, the actual activity to get back? And you technically can, yes, as long as you aren't overdoing it. But actually building the endurance of those muscles helps to get you, gives you much more margin for error when doing this process. You have to do it perfectly, basically, if you're just going to go off of specific endurance alone. And really being responsive to your body. And then even that, you can overshoot things and kind of flare things up, and then you're kind of back in the same position you were. So it really, like, you get so much more margin for error when you're building general endurance as well. But my point of all this is, instead of complete rest or wearing a brace during your activities, just reduce the load to a manageable place, and then you can slowly build that up over time. And there's some other things here about bracing and how it can be useful to wear at night. I think night bracing is great. A lot of times people end up in like this T-Rex position when they sleep because we have these flexion patterns kind of hardwired into us. And if that's the case, those muscles will just be tighter and stiffer in the morning, and having a brace on there kind of prevents that. And that's completely fine. If you want to wear a brace at night, it can be very helpful. But wearing a brace while you're doing your activity and just stress shielding that muscle doesn't actually help that muscle get any stronger or adaptable. It just reduces the load and makes your muscles weaker.
Yep.
So yeah. Any questions about that? Let's see. Is there a way to make that work when you're forced to work at a keyboard 40 hours a week without reducing your hours? Yeah, well, we actually recommend taking breaks more often. In our app, we built this algorithm that calculates how much you should work consecutively if you have to continue working before taking a break. And it's kind of baked into the equations that we in our calculator. But we'll talk more about that later.
Yeah, and I think the other thing is like, if you are still need to work, obviously there's even ways to work with your doctor to get reduced hours, but you can also use other tools to control your cursor, right? People use voice control. That's why it's helpful to sometimes modify your ergonomics to reduce load temporarily. That gives you the ability to still accomplish your tasks, but you have to use that ability or time to increase your overall endurance.
Yep. Waking up from bracing was often not comfortable. I believe that, but it is pretty helpful. Okay, so next we're talking about ice and steroid injections and anti-inflammatory meds. I've lumped all of these together because they all do the same thing, essentially. Their job is to reduce inflammation. And this can actually be okay if you have an acute flare-up. Like, I have a lot of pain today. This is really bad. I just did a long sprint with my hands, and things are irritated and inflamed. And these can actually be okay when used in the short term, but like no more than like 1 or 2 days in a row. The problem here becomes when you start doing these things regularly, and injections are a little bit different. Steroid injections last for weeks, and they cause weakness in the tendons that can potentially make them susceptible to ruptures, which is why I don't really love that as a solution. But if you're really flared up, really irritated, these things can be helpful. But in the short term, if you are using these every day, you are reducing the capacity of your tendons to heal, because inflammation is actually a really necessary part of that healing process. That's how your body heals itself. It's how it builds new collagen in tissues. It's how the remodeling process happens. It's all mediated through these inflammatory chemicals. So inflammation is actually important for the healing process. It's how you get stronger after you go to the gym. When you go to the gym for strength training, you tear your muscles, inflammation rushes into the area, it builds new cells up, it builds more cells up, which is why your muscles get larger, and you actually have an increase in capacity after that, is because your body has gone through this inflammatory process. So that being said, these are good in the short term. I would not rely on these in the long term.
Touch a little bit about cold and heat.
Okay, yeah. What cold does essentially is it constricts your blood vessels. So your like teeny tiny blood vessels, your capillaries, they're responsible for actually bringing blood to the tissues. You have bigger blood vessels like your arteries, which are more visible, and veins that you can see popping out when you're exercising. But the capillaries are responsible for bringing that blood to the tissues directly. They're very small. What ice does is it constricts those capillaries, which causes the blood flow to those tissues to cease. And that slows the inflammatory process down because inflammation is caused by blood flow. When triggered via the like damage to the tissues, but it's that blood that's bringing in the inflammation, essentially the mediators that are responsible for healing that tissue. What heat does, on the other hand, is heat opens up those capillaries, and it also has a relaxing effect on muscles. So heat can actually be great for if you have really tight irritated muscles. The heat on the muscle belly can help to relax that muscle and help you get a better stretch in. It's good to do before activity. You should never ice before activity because muscles will be tighter when you ice them. But heat can be really good to do before activity, before exercising, in order to kind of warm up the tissues. It's the best way to warm up your tissues, though, is to actually just move the muscles and warm them up that way. Both heat and ice have pretty minimal area of effect, penetration depth into the tissues. So you're not getting heat in the center of your muscle. You're not getting ice to the center of your muscle. The best thing to do in order to warm up tissues is to actually go through some movement with the muscles in order to warm them up from internal mechanisms.
So
That makes sense?
yeah. So I mean, all of those things that Elliot mentioned are ways that you guys can restore your HP, right? With the health bar concept, think of those as, hey, when I rest, I am helping my capacity get back to those normal levels. That's why when you sleep, you tend to feel better afterwards. And then, right, you can use isometrics to restore some of that HP or minimize the stress. But the size of the health bar, again, is the most important. And what with ergonomic changes, it changes and reduces the stress per unit time, right? How much HP you lose during the actual work session. If you have really crappy ergonomics, claw grip, holding as hard as you can think of it as losing 5 HP per minute versus 2 HP per minute. And it's pretty marginal in some cases, right? Vertical mouse, the difference between that is it shifts it from the flexor extensors to more of the thumb and radial ulnar deviators, right? You're doing this for vertical mice, but you're using your thumb to press the buttons. You're doing slight pinching with the vertical mouse. But that's why sometimes it shifts the distribution to more thumb-sided pain. Whatever position your hand is in, whatever things you're doing that to control your input devices, those lead to a certain set of muscles and tendons being used. And those muscles and tendons need to have the HP to handle it. You can change the ergonomics all you want, but if you don't have as much HP, you're still going to get to zero. That's just a fact, right? And that's why we can reduce the decay rate. And you can use it as a strategy. Let me swap to my left hand. If I still need to work, let me swap to Talon for now, but not as a way of because you're afraid. It's because you know that, hey, at around 30 to 45 minutes, that's when my tissues start to feel like they, it gets to 4 to 5 out of 10. And you don't want to continue to irritate or lead it into an actual flare up. So you swap to the left hand, then you use Talon for the next 30 minutes. So total, you get like a 1 hour break, then you go back to your right hand. Repeat that cycle. That allows you to still achieve what you need to do. Now, to actually implement this and integrate better overall posture, what we do want to do is, hey, we want to try to be as neutral as possible, because in this neutral position, the muscles don't have to work as hard. They won't fatigue as quickly. Again, less HP loss per unit time. So you want to be more neutral. You want to look top down to see if you're holding your mouse like this while you're moving, to see if you're holding it like this. But recognize, even if you are, it's okay if you have enough endurance. It just means you'll use the side more. That's why there's pros and players and people that use certain types of mouse keyboards that also have no pain. Right? And so you want to look at your keyboard. You don't want to float your wrists. I actually might have it on my screen. I just bought a tool that can give us information on the muscle activity. This is a real muscle activity study of my own hand, and I compared floating wrists versus palm supported typing. And this channel shows the pinky sided wrist muscle, and this channel shows the flexors. So when I'm typing, and every time I press back, right, or escape or backspace, you use the pinky side of your wrist. Press like a plus or something, and it leads to this certain level of contraction. Now, there's not as much, but when I bring it to the floating wrists, what actually happens is, yeah, slight increase in the extensor flexors, but you use the pinky side of your wrist more. I literally just did this today. So basically, it's proven, and you don't even need to use this to figure that out. You just need to look at the movement to figure out, oh yeah, they're just using their wrists more to bend their wrists, so they're going to use it more, right? And so this is obviously, surgery is another really common intervention that is offered by traditional care. And what they actually do is they open up your wrist, they cut that ligament that we discussed earlier, that sandwich that Elliot described earlier. The top of the bread gets cut so that it creates more space for the nerve, right? Because again, the belief is that the carpal tunnel ligament is thickened and there's not enough space there. They can also use an endoscopic, where they just use cameras and use tools with this small area to, in the small tool set, to actually make the small cut along the camera or with the camera, or they do double portal where they have the tool where they cut it above and the camera on the bottom. Regardless, the main goal is to cut the ligament, and there's different healing times of the actual superficial tissues based on that. It doesn't change the tendons, it doesn't change the endurance, and the recommendations are you get back to work afterwards. And that's why it doesn't help them. And what's even more interesting, I'm going to post about this tomorrow in my email and on Reddit. They found that, they do these long-term assessments of individuals and how they respond to carpal tunnel release surgery. And they show that, 60 to 70% report that they get back to function. But they send out a survey to 400 people, and they did this multiple times in multiple reviews. They send out to 400 people that got the surgery. Only 200 of people respond. Half of them respond. And only 60% of those people say that they got a benefit from it. Half of the people that got surgery did not respond. Most likely, and they repeated that over and over. And then there was even another study that showed that 50% of people did not have good outcomes, which supports the idea that with these meta-analyses and reviews of the long-term effects and benefits of carpal tunnel surgery, it's skewed because they only take the responses of the people that may have had better experiences or partially better experiences. And there's even other issues associated with the studies too. But again, it doesn't change the underlying problem. That's why endurance is the big focus here. We keep repeating it. And it takes time for you to change your tissue's ability to handle stress. Muscle, tendon, muscle, nerves, bone, they actually respond pretty quickly within 4 to 6 weeks. 2 to 3 weeks for nerves, 6 weeks for muscles, around 8 weeks for tendons. But it doesn't mean that it takes 8 weeks for you to notice changes in how you're feeling. It just takes time. Typically, our patients report, 2 to 3 weeks, pretty big jumps because their brains are now sending better signals through the nerve changes. And then their muscles are starting to get stronger. And then eventually, they're able to handle more. But I think it's important to recognize that we're not just saying that, at 8 weeks, your tissue's healed. That's not the goal. The goal is that you'll get your first set of adaptations then that will allow your tendons to handle more. If your baseline was, I can only handle 1 hour, then at 8 weeks, it could be 3 to 4 hours. And then at 10 to 12 weeks, it could be 6 hours, right? You still have to do the exercises. It doesn't mean that you just stop. And the goal is never to change the tissue. We're not trying to get it to heal. We're just trying to improve your ability to handle stress, because the tendon cells are constantly changing, and they'll improve its ability to handle stress as you continue to load it. similar to the muscle, similar to the nerves. And so it's not even only focused on improving function too. One thing that I really like to help people understand is the road to recovery is never this straight line up. You feel better, you feel more confident to do more, you get worse, you catastrophize, you get afraid, but then someone that you meet helps you understand a little bit more, so you go up, it goes up and down, up and down. Ideally, the goal is to get you steadily up, but sometimes people fall into these dips and have trouble climbing their way out. And I'll tell you why, okay? The most important thing that we need to do as healthcare providers is help you understand what was the combination of your physical conditioning, your environment, your ergonomics, your posture, your lifestyle, and then how you responded to pain that led to this problem in the first place. Because yeah, let's say there was a magic pill that was like, all right, your tendon's back to normal, and you don't change anything about what you do. You play 8 to 10 hours, 3 days again, your tendons are going to get irritated again because you didn't change the behavior, your understanding of pain, your beliefs about pain. And so it will continue to cause a problem. Even if we give you a new tendon, you're still going to have the issue because your risks of injury are higher because you don't move enough. You get really afraid every single time you deal with pain, and that leads to you doing less, which makes your tissues get weaker. When instead you can, and the difference between a 2-week flare-up or a flare-up that lasts maybe like 2 or 3 days and one that lasts for 3 to 4 weeks is actually just understanding pain, that you don't have to stop everything. You don't have to be afraid, that you can continue to move. You just have to modify or reduce your load, right? Understanding these things is why it's so fucking hard. It's so hard to do it on your own. And people get really discouraged because they think that they've tried everything. They think that they've done every possible thing with the right approach, when in reality, they just give us a chance and we help them understand all of this, they really start to make progress. Now, we went through so much today. I want to obviously give you some time, you guys, time for questions, but also first, before that, what is one aha moment that you guys have had based on every single thing that we talked about? As you guys can tell, there's probably more that we can talk about. I can talk about this for, 6 hours endlessly because there's so many possible situations and scenarios that can occur. I can record a whole course on how to manage this, how to respond to various situations. We could create an app that, takes all of these things into account and automatically does these things for you. Because there's so much information, or we can even write a book. But what did you guys learn? Tell us. Drop it in the chat. While I stand up and do some very healthy stretches.
All right, what did we take away, guys?
Yeah, what did you guys learn?
Good points about pain.
Yeah, fear-inducing pain is most interesting. Yeah, it's real. It's very real. I'll tell you guys some interesting information about that.
Yeah, pain and fear actually have so much to do with each other, and just heightening your expectation of pain, and it's a huge predictor of how much something is going to hurt. And then there's a lot of things that affect pain too, like your sleep, and people on lower sleep end up reporting higher pain for the exact same stimuli on a day-to-day basis. Stress can be a huge part of it. If you're really stressed out with work, and it just kind of feeds into this fear pain cycle. It makes you feel more pain, and then if you feel pain for long enough, it can actually become where everything feels like pain, even just like light touch, even though there's nothing wrong with you anymore.
Yeah, we can get into so much depth of that discussion. Pain science is pretty complex, but basically, our body is really adaptable. The more we deal with pain, the better we are at creating the experience of pain. So, whenever someone says, hey, it could be because you're stressed, we're not actually saying that all pain is in your head. We're never saying that, actually. We're saying that because you've been afraid, because you've dealt with pain for such a long period of time, real changes in your nervous system actually occur. They've documented those changes, and it's called things like smudging, where your representation of your brain changes of your hand. That's why sometimes pain can move around. There's more signaling from the brain to the spinal cord, more receptors, more neurotransmitters are released. The
Archie,
efficiency. Sorry, go on.
Archie, you're talking about John Sarno's technique, right? Maybe if you want to touch on that a little bit, Matt, how
Yeah,
that relates to the pain science conversation.
yeah. I mean, John Sarno's he's only focused on the psychological aspect. So his is good, but most of the research and evidence that we pull is from Lorimer Moseley and David Butler. They're the leading pain science researchers. There's also The Way Out by Alan Gordon. He pulls a lot of really modern research. Some of it's from David Butler and them. But Sarno's method is more that, hey, it's all mental. And as you guys might see based on this, we always have to look at it as a pie chart. There's always going to be a physiologic component, right? We can never take our body out of the equation, just as we can never take our brain out of the equation. The other parts are lifestyle, posture, economics, right? Our body is always there. Our brain is always there. It's always a combination or distribution. In the beginning, it's typically more physiologic, but if we deal with it for a while, it becomes more psychosocial.
Right. Yeah. The amount of that it becomes neuroplastic depends on how long you've been dealing with it, which is how you end up with people that have these like fibromyalgia diagnoses, where everything hurts all the time, everywhere, even though there's no more stimulated pain. It's just this has gone on for long enough that it has snowballed into this behemoth of pain. And there's definitely a time and a place for addressing that. Typically, the first thing that you can do is to address the physiologic, and if all else fails, then start diving more into the neuroplastic side of the pain. But understanding this even at the earlier stages is helpful too. But it's like how much of this is caused by the neurological side of this versus the physiological side of this, your actual state of your tissues. It's different for everybody. So there's no like one size fits all answer. But I think it's a little bit like to critique Sarno a little bit, like he only offers this explanation that it's this neuroplastic part, and I think that's a little bit dangerous when there is a component that is also physiological as well. So it's not all one or the other. And then there's people that are all like, it's all just physiological, it's not psychological, and they completely dismiss that, and that's also
Yeah.
not great. And Sarno wrote that book, I think, what, 70 years ago
It's
at
been
this
a
point,
while.
I think.
Yeah.
So we've had a lot of research come out since then that has like kind of given us a better picture of kind of the entire. But I think he did like revolutionize a lot of the understanding of this pain
The
science, or kind of like
underpinnings
did
of
a lot of
that.
the foundational work for
Yeah.
it. So he opened the door conversation, but I think the conversation has progressed beyond that into kind of some more of these other researchers and scientists.
Yeah, Ben, I wish we had more time to kind of talk about all this, but it's not easy, right? It's hard to understand when you're locked into your own perspective or what it might be. But sometimes it's if things don't make sense of how your pain is behaving. Hey, it's always elevated. It's typical signs are like if it tends to move around, if it's hard for you to describe your pain and can't point to it in a certain location, if you touch something like a mouse and it feels really painful, but then you can go and lift weights or you can go and cook and there's no problems, right? Those are some signs that hey, there may be some central sensitization involved. Now, this is it's not the topic for this conversation. We can get into more depth next time. The reason why I drew this cage is just to this image. This is the last thing, and then and if it's okay with you guys, I want to share something we've built after this. But I want to explain this really cool study that one of the pain specialists that we work with told me about. There's a mouse. He is in a cage. They take this mouse outside of the cage to cage number 2. They shock him. He freezes, and they take blood, and he has elevated cytokines, which means more inflammation. Okay, so he has elevated cytokines as a result of that. Then they put him back into his original cage. They take his blood again, cytokines go down. No more systemic inflammation. Then they put him back in this cage again, but this time they don't shock him. Then they take his blood. He still freezes. He doesn't move. He recognizes the cage. Cytokines go up because he's afraid, right? Fear leads to real changes in our body. It's not just in our head, okay? Our thoughts have a very, very important part on what we feel, how we feel, why we feel what we feel. That's all I want to leave you guys with in terms of understanding more about pain. There's all these ways that you guys can improve your understanding of it. We've written a lot. Now, I don't want to do that. I do want to share something, right? Yes, we do have virtual consultations, but we've built something. We've literally spent the past decade working with clients, and just in the past year, we've integrated that all into this real application that automates a lot of these things so that you can make all those changes, gradually build up your health, make those modifications yourself. You can do it without taking a break from work, gaming, surgery, these stretches, useless exercises, going to doctor's offices. And it's for you if, obviously everything that you guys have experienced and I talked about throughout the presentation, if you've tried all these things and it didn't work, if you've been diagnosed, if you think your wrist pain is unique, trust us. We've seen every one of these situations. We've seen surgery. We've seen people that have had multiple surgeries. We've seen people that have excessive amounts of pain regions. I do want to say, though, this is not something where if you guys want to just buy this app and just follow it blindly without doing anything and hope that the pain will go away, this is actually not for you guys, right? Because ultimately, you will always have to put in some amount of work, right? Again, this is just some of the information and research that we put into it, our own background, our own evidence, our own clinical data. We built the system that you can follow, but not just be a passive user. It's something that you can leverage to teach you more about your body so you can develop your tendon strength, so you can use your wrist more over time. And it teaches you how to safely use your wrist and hand as you're working. And it does this because we've tried to make it as easy as possible. You start by doing some tests, you select a region, you establish your baseline. Because in the beginning, you need to know where you are to get to where you want to be. And so it helps assess everything that you need to assess in terms of how you're functioning, what your endurance is, are there nerve symptoms, is there tightness? And if you want to save time instead of trying to figure it out all on your own, which many do, and it takes them a lot longer, then, and if you want to really learn from us, the real experts that have, I really do think we're the only group out there that has the sheer amount of clinical data on wrist endurance and capacity and being able to match that with certain levels of function. If you want to be able to leverage that and get similar results as, we've helped so many people, whether it be for cubital tunnel syndrome, from 2 years to helping them get relief in 5 weeks, for this professional Call of Duty player, only 1 to 2 hours, then in 4 weeks, 8+ hours, no problem. This is a direct user of our troubleshooter. He was able to get his. I won't drop the actual video, but we have a video of this. You might have seen it in some of our content pieces, but in 4 weeks, he went from being put out of work, put on medical leave, to getting back to work. And, over time, building it back to being able to handle everything that he needed to do, work, gaming, playing piano, doing all of this with just the troubleshooter. Worked with a speedrunner. His name's Happy Hob. And here's what's inside the product, right? You guys, like I said, you get lifetime access only for the people here. You'll get, obviously, the special testing. You'll get the personalized programming, the activity guidance. I'll give you guys a bit more information about that. And then in this special offer, we have access to the Discord, access to this private channel where you guys can ask us questions about your progress. So you're actually still not alone.